so I'll let you. Hello, everybody. Welcome to Grand Rounds. It is truly my honor and privilege today to introduce Dr. Monica Kraft, who, as you know, for the past several months has served as our system chair of the Samuel Bronfman Department of Medicine at the Icahn School of Medicine at Mount Sinai. And as of last Wednesday, she's also formally the Marie M. Rosenberg Professor of Medicine. It's notable that Dr. Kraft is the first person hired into this system chair role from outside the institution in 30 years, since until this summer, she was a professor of medicine and a Robert and Irene Finn Endowed Chair of the Department of Medicine at the University of Arizona College of Medicine in Tucson. As you also know by now, Dr. Kraft is an internationally renowned physician scientist who specializes in clinical and translational research in airway disease, has published extensively on topics of adult asthma and COPD with an H-index of 78. Her work has been continuously funded by the National Institutes of Health and the American Lung Association for over a quarter century. Dr. Kraft received the Presidential Early Career Award for Scientists and Engineers awarded by President Clinton at the White House in 2000. I shared during the town hall introduction this summer how truly impressed I've been by her quick understanding of the complexities of the Mount Sinai health system, by the needs of our doctors, and by the unique position MSBI holds in New York City and in our health system. And now that we've been through a budget cycle together and partnered to put out several fires together, I'm even more glad to have her leadership and support as we plan for the future. So today we'll get to hear more about her work in the clinical realm as she presents about asthma and precision medicine. So please join me in welcoming Dr. Kraft.
Great, thank you, Matt. That was a really nice introduction. Thank you, great. Let me share my screen. All right, can everyone see that? Slideshow. Is that all visible? Great, perfect. All right. Well, I'd like to talk to you a little bit about some research I've been involved with, as well as and how that sort of moves over to the clinical space. And so asthma is my area of interest. And so these are my disclosures and objectives. Now I'm seeing you are screen sharing. Can you all see that? I was going to move that. Let me move that up. Move it up here. There we go. Okay. So in the next 45 minutes or so, would like to, oops, where'd it go? Oh, hang on a second. Let me go back. Let's go back. Here we go. To talk about new areas of asthma pathobiology, and then to talk about precision-based approaches to the study and the treatment of asthma. And if you don't mind, if you have questions that come up, just put them in the chat as we go, and then we'll go over them afterwards. And hopefully we'll have a great discussion. But I thought I would start with a case. It's a patient I took care of at Duke a few years ago who was a 38-year-old female who presented with severe persistent asthma on chronic oral steroid therapy, who presented with increasing shortness of breath and worsening wheezing. She was diagnosed with asthma at age 22, has had at least one hospitalization per year, plus 2 to 3 exacerbations, treated as an outpatient. She'd been intubated once for status asthmaticus, has been on oral corticosteroids intermittently and now is on them persistently, and has the comorbid conditions you might expect to see with somebody who has severe asthma, including gastroesophageal reflux disease. She has allergic rhinitis as well as chronic rhinosinusitis, has a history of nasal polyps, depression, and osteopenia. Prior to her exacerbation, her baseline symptoms are pretty much daily. Shortness of breath and wheezing with limited activity. She needs a lot of albuterol, which of course is our short-acting bronchodilator, 4 to 5 times a day, not what we hope for. But I do believe she was adherent with her medical regimen. So this is her problem list, as I mentioned. She also has aspirin sensitivity. So she has Samter's, what we call Samter's triad, which is or aspirin exacerbated respiratory disease, which is aspirin sensitivity, nasal polyps, and asthma. Her med list is what you might expect to see in a patient like this. She came in on methylprednisolone, which is Medrol. This was given prior to when she began experiencing this exacerbation, was on a taper, obviously failed outpatient therapy, high-dose fluticasone, salmeterol, and then montelukast, albuterol, ipratropium nebulizers, albuterol metered dose inhaler, omeprazole for reflux, loratadine is an antihistamine, fluticasone nasal spray for chronic rhinosinusitis, calcium, vitamin D, and you can tell this is a little while ago now because this patient was on alendronate, which we don't use as much. We do still, but not as much as we used to. Social history, married with 3 children, has 2 dogs, outside cats, office work with no exposure, and she's a never smoker. Her mom had asthma and atopic dermatitis. On physical exam, she had prolonged expiratory phase or prolonged expiration with moderate air movement and diffuse expiratory wheezing. And some biomarkers that I'll talk about a little bit more later. Her peripheral eosinophils were at 350 per microliter. Anything above 150 we pay attention to, so that's elevated. And the FeNO is exhaled nitric oxide. We measure it in exhaled breath. It's a biomarker that's reflective of airway inflammation. And hers was 40 parts per billion. So anything above 20 we pay attention to. Her IgE, her serum IgE, which is an antibody we associate with allergy, was 50, not all that elevated. This is her chest x-ray. Hopefully you can see my little pointer here. She's got some flattened hemidiaphragms. Heart size is normal. Lung fields are pretty unremarkable. Trachea is midline. So not a whole lot of activity there. No infiltrates. And then we were able to get pulmonary function tests. And so first, if we look, sensitive. If we look at the forced vital capacity, this is how much she could exhale in 6 seconds. She was able to exhale 2.4 liters compared to a reference of 3.05 that's based on age, height, and gender, so 78% predicted. And anything 80% and above is normal, so not too bad. However, her forced expiratory volume in 1 second was quite low at 1.27 liters, 48% predicted. So this is, you should be able to get about 80% or more out in your first, within 1 second in your exhaled breath, 80% of your lung volume. And so she clearly has what we call expiratory flow limitation, resulting in this FEV1 to FVC ratio. It's quite reduced to 53% compared to her predicted, which is 86. So severe airflow limitation. So what's asthma? Well, it's a very heterogeneous inflammatory respiratory disease. It's actually the most common, affecting over 350 million people worldwide, 25 million in the US, children and adults, and carries a huge economic burden of over 80 billion with a B. These are older data. It's hard to get some recent data. I suspect it's going to be higher because cost of medications have certainly gone up with the biologics, but this includes cost of medications, hospitalizations, emergency department visits, and lost productivity from work and school. And the symptoms are relatively nonspecific: chest tightness, cough, wheezing, shortness of breath. There is no cure, and it can be fatal. And on this cartoon, you can see a normal airway, which is open. You can see the smooth here, and this is the airway lumen. You can see in asthma, there's too much smooth muscle. And the cells that line the airway opening, they're called airway epithelial cells. I'm going to be talking a bit about that today. And in the setting of an asthma exacerbation, asthma attack, you can see this airway is constricted and there's even mucus in the lumen. Now, mucus is something you might think of with COPD, bronchiectasis, but it's actually a real problem in asthma as well. And it can fill up the airways and often is what prevents patients with very severe asthma from ventilating and can be a cause of death. So my research interests are listed here. I won't be talking about all of those today, otherwise we might be here for a long time. Airway biology, mechanisms of inflammation and innate immunity, the microbiome in asthma, biomarkers, genetics, genomics, precision medicine, I'll be talking about that, and some translational approaches in clinical trials. So first I'm going to talk about an area that you might not associate with asthma called surfactant. Now you might remember that surfactant are associated with giving it to babies who are born with respiratory distress. And so that is one of the functions, to reduce surface tension, and that's carried out by surfactant protein C and the lipid portion of this big lipoprotein complex. Surfactant also has some host defense properties, really carried out by surfactant proteins A and D. And I'm going to be focusing on surfactant protein A, or SPA, today. And hopefully I'll convince you that there's some very interesting anti-inflammatory effects of SPA that are relevant to asthma. Now, SPA is made in the lung. It's made in the very distal lung, the alveolar type 2 cells, but also along the airways by a cell called the club cell, which is one of the cells that make up that airway epithelium that line the lung. You can also find it in the sinuses as well as the gut, so mucosal surfaces. So it's a big octadecamer. The lipoprotein complex looks like a bouquet of flowers made of monomers that form trimers to form this very big octadecamer. And these monomers, this likes to switch, it's very sensitive. These monomers have domains relevant to their function. For instance, the collagen domain is important for oligomerization, receptor binding. And this lectin domain, I'm going to be spending some time on. It's our favorite domain, responsible for carbohydrate and lipid recognition and also pathogen recognition. So our 30,000-foot hypothesis is that one needs an adequate pool of functional SPA to have normal lung function. But in cases where there may be low SPA, which we've also published about, I'll tell you about that, or dysfunctional SPA, these two situations contribute to the presentation of asthma. So how's that? So years ago, I like to say when I was a pup, my lab and I published this paper that was actually long-standing work we'd even started well before this, looking at SPA and asthma. And how did I get involved in that? Well, it was really with a multidisciplinary grant I was part of when I was at National Jewish Health, really in the 90s, leading into the early 2000s, long before some of you were born. And so we actually had a mechanism of research where we do bronchoscopy-based research in patients with asthma and healthy volunteers in a very safe, well-validated way. We can actually look in the lungs with the scope and brush the side of the airways very gently and obtain these airway epithelial cells. And we take them back to the lab and we can culture them. What's really interesting is when you take them out of the body, they behave differently. The asthmatic epithelial cells behave differently compared to the normal. And so that really allowed us to understand how these epithelial cells handle these insults, whether they be infection, allergen, pollutants, because they're kind of the first line of defense. And you know the lungs exposed to the environment 24/7. So they're really the first line. And so what this was is when we do these bronchoscopies, in addition to brushing the airway, we do what's called bronchoalveolar lavage, where we put some saline in, some salt water, take it out. And in that salt water, we can see some proteins we can measure, other mediators, and we can actually extract surfactant protein A. There's enough of it where we can extract it and actually work with it in the lab. So what we did is we performed bronchoscopy in a group of patients with asthma and normal healthy volunteers, and we went ahead and extracted that surfactant protein A, took those epithelial cells back to the lab, and we cultured them at what we call an air-liquid interface. So what they do is they differentiate, they form cilia, mucus, just like they do in the lung. So it's a very unique way to be able to look at cells directly from patients outside the body. And the closed bars here are from the asthmatic patients. And there was a time when we were very interested in Mycoplasma pneumoniae, because that's an atypical bacteria that causes asthma exacerbations. So we can infect those cells, that's what MP stands for. And we looked at a particular readout. So we infected the asthmatic cells with Mycoplasma, and we looked at a mucin gene expression as our readout for this experiment. And as I mentioned earlier, there's MUC5AC is a mucin protein in the asthmatic lung. It's actually in the normal lung as well, but there's too much of it in the asthmatic lung. It can cause problems in that too much of a good thing, as I mentioned, can really occlude the airways and really actually impede mucociliary clearance in many cases. So what you can see is when we infected the asthmatic cells with Mycoplasma, there was lots of this mucin gene expression. And these are the normal cells. Here, the open bars, there wasn't a whole lot. When we took SPA from a normal healthy volunteer, exposed the cells to that, and then infected the cells, you can see that mucin gene expression was much lower. When we did the same thing with asthmatic SPA, you can see it didn't quite do as good a job. And then this last condition was really to rule out the presence of an inhibitor. So we concluded that maybe the asthmatic SPA really didn't function very well. So that was sort of our first observation, but we didn't know why. So as this work was moving along, I moved to Duke to design and direct an asthma allergy airway center, and had the really fortunate opportunity to meet Jo Ray Wright, who was dean of the graduate school at Duke. She's a basic scientist who did a lot of work in the SPA space, and we were able to be collaborators as well as friends. And unfortunately, she left us too soon, passed away of breast cancer at age 56. So we call her our spiritual leader, and this will become more apparent as I continue this talk. But I just wanted, it's amazing that you meet people in your life and you don't always know the significance when you first meet them, but she certainly was a major force, I'd say, in directing my career. And what her lab had published, which was also really interesting to us, is they looked at SPA deficient mice. And so they exposed these mice to ova, which is a way of recapitulating an asthma model in mice. What was interesting is when SPA was absent, these mice had a very exuberant allergic inflammatory response. So there were lots of eosinophils. You can see this last condition here. These are two cytokines, interleukin 4 and 5, that we associate with allergic, or what I'm going to call type 2 asthma. And that will become clearer throughout this talk. But those were very when SPA was deficient. And then of course, IgE, the the molecule we associate with, the antibody we associate with allergy was also elevated in these SPA deficient mice. So when we put that together with this human observation that maybe asthmatic SPA didn't work very well, we asked the question, what role does SPA have in asthma? So when you look at mouse models of asthma, there's a number of them. You can look at that OVA model that I mentioned. You can actually expose the mice to house dust, which is probably the most common model used now. And then we also look at what we call an interleukin-13 model. And so interleukin-13 is another one of those cytokines we see in this allergic or eosinophilic or type 2 asthma. And it's really responsible for a lot of outcomes in human asthma. It can cause bronchoconstriction, it enhances mucus production, and it can cause production of collagen and other mediators that result in this phenomenon called airway remodeling. So if you've ever seen patients that have very low lung function in asthma and don't really bronchodilate very well, we think those patients have airway remodeling, and IL-13 is really important in this process, very important in human asthma. So we have an IL-13 exposure model that we look at in mice. So this is a busy slide. I'm going to take you through it. So this is an SPA deficient mouse was exposed to IL-13, many more than one mouse. And you can see again, just a really exuberant response relevant to asthma when you take SPA away. So in this case, this ladder bar here, I hope you can see my pointer, is total cells. You can also see lots of eosinophils in panel D and neutrophils. You can see this MUC5 gene expression is also quite elevated. This PAS score is actually a mucin protein, so it's actually staining for the protein in the lung, is also elevated. And then some readouts in panel G. KC is interleukin 8, which is very important for reflux, which we can see in severe asthma also. Eotaxin is an important mediator in human asthma, and IL-6. So all of those were elevated, especially in that SPA deficient mouse. So this really confirmed a lot what Amy Pasva and Joe Ray Wright had published. And again, just trying to link our this SPA asthma relationship and making it stronger. So when we look at the mouse lungs, you can see in the wild type situation, that's WT exposed to saline. This is a normal looking lung. Even when the wild type's exposed to interleukin 13, in this case, you can see all this pink staining is mucus. In the SPA deficient mouse, you can see when exposed to IL-13, there's lots of pink. And I promise we did not cherry pick these images. They all look like this. And then the two panels on the right with IL-13, you can actually quantify the amount of mucus. That's what the open bar shows, and it's elevated, and with an OVA model too. So either way, when you take SPA away, regardless of how you challenge that mouse relevant to asthma, you see this very exuberant response. The good news is you can rescue these mice. You can give them SPA back, and that's what this first panel shows. You can see that with SPA rescue, you can decrease the mucus, that's that PAS score, and you can decrease eosinophils. So that's good news. However, this is mouse asthma. We're talking about human asthma. So how do we get at some of these observations in humans? And so as I had mentioned earlier, we do bronchoscopy, and it's a way of trying to look at epithelial cells, but you can also look at nasal epithelial cells as well through some brushing. And if you ever look on YouTube, I actually did a video. My laboratory manager did some brushing on me because we had to put a video together for some collaborators in Europe. And we thought, well, how are we going to teach them to do this? So we recorded a video. It's on YouTube so they could see it. So that was interesting. But it's important. If I'm going to ask participants to do these studies, I have to do them myself. So you can look at nasal epithelial cells, which are a surrogate for bronchial epithelial cells. You can get the proximal airway epithelial cells by brushing, like I was telling you. Now the lung branch is 23 times. We can probably get the first 3 or 4 generations or so. And we can even do distal brushes, which we're actually looking to do because we think that those distal epithelial cells in the smaller airways are different than the proximal. So there's just a lot of ways of really trying to look at human asthma in very well phenotyped patients to understand the human condition a bit better. So what you'll see is we go back and forth from mouse to man in our work. And so these are human airway epithelial cells from asthma and normal participants cultured at this air-liquid interface. In this case, in panel A, we expose them to IL-13. You can see in this case, we're looking at IL-8 increased. And if you look below in panel C, again, you can see that MUC5 gene expression increased like we'd seen before. If you look at panel B, if you expose those cells to SPA, and this is functional SPA, of course, you can see that IL-8 goes down, and in panel D, MUC5 gene expression goes down. So SPA has some of the similar effects in the human condition, although just looking at one cell type, not the whole organism, of course. So how does it work? So we took epithelial cells from patients with asthma and non-asthma, and we did what's called a Western blot. So you take the protein, you put it on a membrane, and then you can really look at maybe some mechanisms. And one of the mediators produced in the setting of IL-13 associated inflammation are those intermediate signalers called STAT3 and STAT6. And these eventually lead to a pathway that's rather complicated, but ultimately to eosinophils, mucus, etc. So these STAT mediators are really important in really driving that whole process. So we wanted to understand how SPA worked, and I'm culminating a lot of work into a couple of slides. But what we showed is when you expose these asthmatic epithelial cells to IL-13, you can see this, what we call this phosphostat3. So this is activated STAT3. But what's interesting is you don't see it in the non-asthma condition at all. There's just not a lot of STAT3. STAT6 is also an important mediator, and when you use IL-13, you can see that you can see the STAT6 phosphorylated, but SPA doesn't do very much. If you look back at the STAT3 blot, you can see SPA decreases STAT3, but only in asthma. So we think SPA really behaves as a STAT3 inhibitor, not as much impact on STAT6. So there's some specificity there. And in addition, there may be more to the story, and that we found an interesting paper, an older paper from PNAS, suggesting that interleukin-6 may be important in this process as well. And again, this is a signaling work where IL-6 associates with its receptor, and then brings in the epidermal growth factor receptor to lead to rephosphorylation of STAT3 in this positive feedback system. And so the bottom line is we think that IL-6 is actually an important part of this whole mechanism by way SPA works as well, because we think that in an SPA deficient mouse that you expose to IL-13, there's lots of IL-6 around. And when you inhibit IL-6 prior to IL-13 exposure, you can see that mucin gene expression goes down, and so does eotaxin in this case. So we think SPA may have actually significant effects on IL-6 as a way of decreasing the STAT3 activation. And so that we're still working on the exact mechanism, but this is really our major hypothesis right now. However, humans don't run around with complete SPA deficiency. So what's going on with human SPA, and why are we seeing this dysfunction? So we have two pathways that I mentioned earlier on. There can be low levels of SPA, and we actually published that in patients who have asthma who are obese, they have less SPA. So that may be one mechanism by which SPA is less functional if there's just less of it around. But is there any genetic variation that might lead to dysfunction? And so we went back to our monomer, and so we went ahead and sequenced the two genes that are really responsible for SPA, SPA1 and 2 genes. And there are particular polymorphisms that are associated with amino acid changes that we think affect function. And so this is the SPA1 peptide. And you can see that at position 50 and 219, there are amino acid changes there. In SPA2, there's an amino acid change at position 91 in the collagen domain. But we found a very interesting amino acid change in position 223 of this lectin domain. And as you remember, the lectin domain is responsible for carbohydrate, lipid recognition, pathogen recognition. So it turns out that this polymorphism is pretty common. So if you have two copies, there's a substitution of a glutamine for a lysine at position 223 of this lectin domain on this SPA peptide. If you have two copies of the minor allele, that's about 10% of the population, but 30% of African Americans. And what's interesting about that is African American patients tend to have more severe asthma as a rule. If you have two copies of if you've got two copies of the major allele, you will have a glutamine at position 223. So how meaningful is that? Well, we went ahead and sequenced the genes for SPA1 and 2, and then looked at readouts in asthma that we thought was important. And you remember we talked about this FEV1 earlier in the talk. So this is looking at all our participants. Those who had two copies of the minor allele had lower lung function than the heterozygote and the major allele. This is by percent predicted FEV1. And when we looked at only asthma, we saw that was even more prominent. So two copies of that minor allele, meaning they had a lysine at position 223, had lower lung function. We also looked at an asthma control questionnaire score, which you may be familiar with. It's a questionnaire that I use in clinical practice to give me a sense of how well controlled a patient's asthma symptoms are. And the higher the number, the worse the control. So patients who had 2 copies of this minor allele had a higher ACQ or worse asthma control compared to the heterozygote and the major allele, interestingly. But I think what really got us excited is we took the surfactant protein A that we'd extracted from the bronchoalveolar lavage, and we looked at it by genotype and looked at its function. And in this case, we looked at how well that SPA suppressed that mucin gene expression after mycoplasma infection, hearkening back to that very first slide that I showed you. And it turns out that the major allele, if you had 2 copies of the major allele, that surfactant protein A did a great job suppressing this mucin gene expression. If you had the heterozygote in the middle, if you had 2 copies of the minor allele, that SPA didn't work well at all. So it appeared to have there's genetic variation in this SPA function, particularly in the readouts we consider important in asthma. So we asked the question, can we actually replace that defective SPA? And can we think about a therapeutic for asthma? Now, the problem with SPA is, if you remember, it's this big bouquet of flowers, very sticky. You can't really put it in an inhaler. And so we thought, well, maybe we can design peptides that span that position 2, 2, 3 of the lectin domain that are maybe smaller, 10 to 20 amino acids in size. And maybe that's something we can put in an inhaler and use as a therapeutic. And that's where our company, Recedo, was born. And Ray, of course, comes from Joe Ray Wright, our spiritual leader. Cedo is Latin for calming. And so, of course, we know no one's ever going to want this company name, no trademark issues, I'm sure, but it means something to us. And my co-founders, pictured there, Julie Ledford, she was in Joe Ray's lab as a postdoc, came over to my lab for a period of time, and then we moved to Arizona, and she's an associate professor in the Department of Cellular and Molecular Medicine, the University of Arizona, and a funded investigator in her own right. And so she comes at this from the PhD perspective. She's very translational. I'm a translational MD, and so it's a really interesting partnership, and I really thank her for that, because I think we're very excited about the possibilities here. So again, focusing on that lectin domain in particular, and it turns out these tiny little peptides may be as efficacious as that full protein. And so this is, again, looking at the mouse, the SPA deficient mouse, challenged with house dust mite, typical asthma model. You can see lots of eosinophils, but if you give the mice a 20 amino acid peptide or 10, you can see this nice reduction in eosinophils, and then the panel on the right, a nice reduction in mucus. So that got us very excited that just that little peptide in that region of this very protein seems to recapitulate some of the functions of the whole protein that we care about in asthma. But I think these data got us the most excited. So if you know anything about asthma drug development, one of the areas that's looked at is this phenomenon called airway hyperresponsiveness or airway twitchiness. So that's a phenomenon that if any of you who have asthma or know somebody who does, goes out in that cold weather like this morning, takes a deep breath and feels chest tightness, cough, or wheezing. That's airway hyperresponsiveness. You can actually create that with a substance called methacholine, and we actually use methacholine challenges clinically as well if we're not sure about the diagnosis of asthma. In this case, you can actually give methacholine to a mouse after you challenge it with house dust mite. And what these data show is that when these mouse received the peptide, that they had a nice reduction in this airways resistance, which are the solid line, and the dotted lines are what the airways resistance is with the peptide. So that got us excited that maybe at least in a whole organism, which is a mouse at this point, we are seeing some important readouts we associate with asthma. But then again, we're not all about mouse asthma, we're about human asthma. So take this peptide back to our normal cells and our asthma cells after exposure to IL-13, and we can see this nice reduction in MUC5AC. And actually we see it in the normals as well, but much more prominent in asthma, and it's significant. So this is exciting because this peptide seems to have benefit in both mouse and man. So where do we go from here? Well, we think it's novel to replace SPA. It seems to modulate this type 2 allergic inflammation, which is a most common asthma phenotype. Seems to recapitulate the readouts that we care about in asthma in this case. And we've gone on to actually determine that the SPA induces eosinophil apoptosis, which is cell death. And in this case, that's a good thing because there's too many eosinophils in the lung in the setting of asthma. And so we don't need that many, so cell death is okay. And it also decreases mucus produced by that airway epithelial cell. Because it's produced by the lung, we hope that it reduces the likelihood of toxicity, but actually what we're doing now is these peptides can be degraded in the lung very easily because there's lots of enzymes and such. And so we've tweaked the peptide and we've pegylated it, lipidated it to produce what we call peptidomimetics. And that's actually what we're moving forward with as a therapeutic, because we think it decreases the risk of degradation and has greater efficacy over time. And so we're in the process of doing some aerosol development, dose ranging, and toxicity studies now with the help of NIH. And if we can transcend that valley of death where drugs go to die, we can hopefully apply for a new drug submission in about 2 years. So more to come. We also have shown some efficacy of this peptide in SARS-CoV-2, which I won't be talking about today, but that may be another interesting direction to go. And certainly other diseases where mucus is very common, like COPD and CF, cystic fibrosis. All right, so now I'm going to switch gears and talk a bit about precision-based approaches to the treatment of severe asthma, but I'll also say that many of these techniques and approaches are moving into the mild to moderate asthma space as well. I want to make that clear. And so this is about really, when we think about asthma as a heterogeneous disease, we think about the various pieces that compose the clinical presentation. It can be exacerbations, symptoms, lung function, the type of inflammation, when did it start, and all of that is really to understand disease mechanisms to guide therapy so that you can give the right medicine to the right patient at the right time. And that really brings us to this concept of phenotypes, which is really observable properties of an organism that are produced by the interaction of the genotype and the environment. And these phenotypes can be based on clinical characteristics, triggers, general inflammatory processes, but they don't necessarily suggest an underlying mechanism. So the holy grail is really the endotype, which is the specific pathway driving presentation of that phenotype. And then you can potentially create or offer therapies around this. And what's very cool in the asthma space is that we have these biologics at our disposal that target specific pathways that we think contribute to these asthma phenotypes. Now, one of the challenges, certainly as a resident, is that when you see patients, in the hospital with an asthma exacerbation, it's, frankly, not all that interesting. I know you have to give them very high dose steroids, bronchodilators, and you hope for the best. It's really in the outpatient arena with these biologics is where the nuance is. So if any of you are interested in learning more about this, certainly let me know, because we can make sure that you get exposure to the right people who are doing this kind of work. So in 2022, moving into 2023, can't believe I'm saying that already, there's really two buckets of asthma. There's type 2 and non-type 2. Sounds pretty simplistic, but under those two, there's some subphenotypes. So type 2 asthma is really what we've been talking about a lot today. Our patient has type 2 asthma that I presented, and certainly the SPA work is really focused on type 2 asthma. Think about eosinophils when you think about type 2. That's probably the best way to think about it. And that's about half the asthma patients. So it's not all of them, but it's probably a common asthma phenotype that you are familiar with, especially this early onset variety that comes on in childhood, is associated with other atopic diseases like allergic rhinitis, atopic dermatitis, and it can progress to mild or severe disease, and it can be exacerbated by obesity. Then there's a later onset variety of type 2 asthma. You'll notice our patient, her asthma onset was age 22, so she would be considered later onset. And this type of asthma can be very challenging to take care of. It can be associated with lots of eosinophils, lots of sinus disease, this aspirin exacerbated respiratory disease like our patient has, not as much allergy, whereas the early onset tended to have more allergy in the history. And obesity tends to be very prominent in this phenotype, and it can certainly be exacerbated by or associated with obesity. And then we have what we call non-type 2, which is the other half. And this is a type of asthma that, in my opinion, really represents an unmet need. And because we don't necessarily understand the nuances as well, there tends to not be eosinophils. So that's important to know. It doesn't respond as well to corticosteroids, and there is a linkage to obesity. And you can see neutrophils in many cases, but there can also be an association with infections, like our mycoplasma infection, environmental exposures like smoking, ozone, pollutants, etc. So this is a little cartoon where I've sort of put them all under these two buckets. And you'll see that under the type 2 bucket, there's this allergic asthma, this early onset. There's actually kind of two types of late onset. There's late onset and very late onset. There's also this exercise-induced asthma, which exercise can actually make any of these phenotypes worse, but sometimes there can be one just by itself. And I often get referrals from athletes who are who have symptoms at very high performing levels. And the question is, do they have exercise-induced asthma, vocal cord dysfunction? So I spent some time, looking at that. I don't know if I'll get those referrals in New York. I hope I do, but I certainly had in Arizona and at Duke. And then on the non-type 2 space, you can see this neutrophilic. There's also a type of non-type 2, which doesn't have any inflammation. It just has a lot of smooth muscle, collagen. We call that polygranulocytic. I would say that's probably the least well understood. And of course, those associated with infections and pollutants, environmental exposures. And this obesity, you see, I've kind of straddled the middle because obesity can make type 2 asthma worse, but it also creates its own phenotype. And there actually is such a phenotype associated with metabolic syndrome and high interleukin 6 levels. So that's something that we're looking at in the PRECISE trial that I'll tell you about. So how to figure out what kind of asthma a patient has in the clinic? Well, we use biomarkers. And so what biomarkers do we have? Certainly there's sputum eosinophils would be great to have, and it's a great way of looking at the airway without doing bronchoscopy. But unfortunately, it is not a very easily clinically accessible test. There's nuance about processing that's really prohibited it from being CLIA approved. So we unfortunately don't have that available. But we do have exhaled nitric oxide, as I mentioned, and that actually is indicative of this IL-13 induced inflammation, just FYI. So our patient had an element of that. She had 40 parts per billion, anything above 20. So in my patients with severe asthma, we get this at every visit. Blood eosinophils, also important. You can look at that. You have to send patients to the lab, and there is a circadian rhythm around that. So, but they're still very helpful. IgE, we mentioned. I actually like to get allergen-specific IgE because total IgE is less informative. So you can do that by skin testing, or you can do it with blood testing, which is what I tend to do more of unless I'm with my allergy colleagues. And there are 3 biomarkers under development that I'll just mention. Urinary bromotyrosine, which is the Cleveland Clinic group is really moving this forward. It's a urine test that's indicative of eosinophilic inflammation. There's club secretory protein 16. This actually could be maybe a biomarker, certainly for asthma, potentially COPD. And it's also produced by those club cells in the lung that I had mentioned that also produce SPA. And then eosinophil peroxidase, which is an enzyme that activated eosinophils produce when they lyse. And you can measure that by nasal swab, and the Mayo Clinic Scottsdale group is working on that. And this could actually be a very interesting point of care biomarker that I would love to see in the next few years. So I'm hopefully I'll get to come back to you and tell you more about that. So this is a busy slide, just shows you what treatments are approved in the type 2 asthma space. So all the red boxes are biologics that are approved. You can see we have biologics against targeting interleukin 4 and 13. And interleukin 5, those I've been mentioning today. Omalizumab targets IgE. And then TSLP, which is thymic stromal lymphopoietin. You can see why we like to say TSLP. Produced by the epithelium, that's the newest one. I'll talk a little bit about the biologics just so you've heard the names, because you see them on TV a lot. There's a lot of direct-to-consumer advertising. So I figure we as doctors ought to at least know a little bit about them. And so Xolair omalizumab was the first biologic. It was approved in 2003. It's almost going to come off patent. And it binds to IgE and takes it out of circulation. So it's really for that patient with asthma who is driven by allergy. And it turns out that if you have severe asthma that's allergen driven and you have an exhaled nitric oxide greater than 19.5 parts per billion or eosinophils greater than 260, Xolair or omalizumab will be effective for you in decreasing asthma attacks. And that's what these biologics really do. They mainly focus on asthma exacerbations, but they can also improve lung function and symptoms. So this was the first one. So it's a very narrow group of patients. We also have several that focus on interleukin 5, and this is important for the eosinophil survival and maturation. So if you can take IL-5 out of the mix, then you can reduce those eosinophils. And it's really great for those patients who tend to have high eosinophils above 300, like our patient today. And just the 3 names so that you've heard of them, because these are on TV. Nucala is mepolizumab. It's an IL-5 inhibitor. Reslizumab also inhibits IL-5, called Syncare. It's the IV form that we tend not to use as much. And then Fasenra or benralizumab is the IL-5 receptor inhibitor. That's also lots of advertising on TV. Another one, Dupixent, that actually inhibits IL-4 and 13. So two cytokines we think are pretty important in this type 2 asthma. We've seen lots of nice benefits on lung function, exhale nitric oxide, as well as asthma attacks. And this is approved for both moderate and severe asthma. So not just the most severe. And again, those patients who tend to have higher exhale nitric oxide tend to do better and eosinophils with allergy. And then the newest kid on the block, which is tezepelumab or Tezspire, inhibits that epithelial product TSLP. And it also has improvements in exacerbations, lung function. But what's interesting about this one is it also has effects in those patients who don't have eosinophils, who have this type 2 low asthma. And so this is actually I'm very happy about this development because we have far less to offer in that type 2, non-type 2 space, as you can see in this slide here. The red boxes are approved. You don't see much. The blue is where there's certainly treatments under development. Not as much activity, certainly, compared to the type 2 space. So at least we have a couple of options. So I'm going to close with a couple words on the PRECISE study. And this is one we are doing here at Mount Sinai for severe asthma. And it was there's an NIH-funded consortium that was funded a long time ago. COVID slowed us down by a couple of years. And that's why it was formed in 2017 and we're still going. We have 10 clinical centers that have partnerships to really look at biomarker-defined adults and adolescents with severe asthma. And these are the different places around the US. So I was with the Arizona partnership initially because that's where we wrote the grant, but I was thrilled when Mount Sinai joined us pretty recently because we wanted to add more sites. And so working with Linda Rogers, so still get to participate in PRECISE, which is wonderful. And so the idea is to develop novel therapies that work in biomarker-defined subgroups and optimize those targeted for treatment. And so I'll tell you how it works. There's 5 different interventions. We use what's called an adaptive platform design. So for those of you who don't know what that is, I wouldn't be surprised because I didn't know that much about it either till PRECISE came around. It's been used really in the oncology space for a number of years. And the idea is patients are well phenotyped, like we've been talking about, like lung function, biomarkers, exacerbation history, you name it, medications, comorbid conditions. And then they get randomized to one of 5 interventions that they are likely to respond to based on a priori hypotheses. Then when they go through a period of time, a 4-month treatment period, then they do a washout, then they get to go to another treatment. Then they get to go to a 3rd treatment. So they get up to 3 different treatments in this study, which for a patient, I think is pretty cool because oftentimes most clinical trials are placebo, drug, and you have a 50% chance of getting placebo. In this case, of your 3 interventions, 1 might be placebo. So you've got 33%, but it doesn't have to be. So that's, sort of exciting in that there's multiple different therapies to try. And then as patients come into the study, real-time data analysis is performed. And for instance, if there is an intervention that nobody responds to, it's taken out and another intervention is put in. And then subsequent patients who come in, then there's more knowledge about what they're likely to respond to and what they'll be randomized to. So that's what's called the adaptive design. It adapts real time. And so our outcomes are actually looking at several lung function, symptoms, and exacerbations, as you might guess. So this is just a schematic of how it works. There's a 2-month run-in, 4 months of a treatment, and then 1 to 2 month washout, re-randomization based on biomarkers to another treatment or placebo, and then re-randomization again. And then we collect lots of information, symptoms, then spirometry, which is lung function, lots of things in blood, eosinophils, IL-6, neutrophils, DNA, RNA. We do induce sputum to look at eosinophils, neutrophils, IL-6. We're looking at exhale breath condensate and CT. So we're developing a very rich data and sample repository through the study. And these are the treatments, which are not the typical treatments you might think about. We've repurposed an anti-IL-6 from the rheumatology space. And remember how I mentioned that phenotype associated with obesity and high IL-6 levels. So we think that that's the phenotype likely to respond to this. Imatinib is a c-KIT inhibitor. This has been studied in some smaller studies in those patients who have a lowish eosinophils, less than 300 are likely to respond. The third intervention is a medium chain triglyceride, which is a food additive made by Nestle that has a weight loss benefit. And in those patients who have exhaled nitric oxide greater than 15, our hypothesis is that these will be the responders to that. Bronchovoxome is a bacterial lysate that's actually gram-positive and gram-negative bacteria taken orally. It's been approved in Europe for 20 years to ward off respiratory infections. And in some smaller studies showed that it had some benefits in asthma. So we think in eosinophilic asthma. And the last intervention is cavasonstat, which is an entity that inhibits an enzyme in that airway epithelium that induces bronchoconstriction. And we think there's a genotype associated response. So inclusion, just for your knowledge, if you have patients who are basically on high dose inhaled steroids, long-acting beta agonists, like the Advairs of the world, the Symbicorts of the world, Deleras, and maybe even another controller, and they're still having poor symptom control, they have low lung function, or they've had an asthma attack in the last year, they would qualify. Pretty simple. So if you feel like you have those patients you think would be interested in participating in such a trial like this, we are actively recruiting and would love to hear from you. The only thing about exclusion is the smoking. This has been, it's been kind of a challenge. Less than 5-pack year history, and no vaping. We know vaping is a huge issue especially among our youngsters, and so they can't have done any vaping really in the last year. So that's been kind of a challenge as well, because it's very common in the community. But other than that, they can be on biologics, they can be on oral steroids. So certainly, if there's any patients you think might be interested, let me know. So I think our understanding of the biology of asthma has improved dramatically. I think because we understand the immunology so much better, that we have treatments now at our disposal that we didn't have before that we can offer these patients. Because back in the day when I was training, we only had prednisone. And I will tell you, the ravages of prednisone are enormous. And so I'm just so pleased that I have very few patients now really on oral prednisone. And if they are, it's usually on the low dose, maybe 10 milligrams or less. And so very, very gratified about that. There's something we have to offer our more severe patients. But asthma in general is complex, with perturbations of airway structure and inflammation intersecting with early life events, genetics and comorbid conditions. And then I think an understanding of the heterogeneity is now allowing us to personalize therapy. And one thing I will mention, even in our mild to moderate patients, there are patients that don't have eosinophils. And so this is an area of active investigation. Now inhaled steroids are first-line therapy and should continue to be. But down the road, I think we're going to get more nuanced in the mild to moderate space as well. And in those patients who don't have eosinophils, we may offer something else as a treatment. There's a number of options. For today, I'm not recommending that, but down the road, we will get more nuanced in the mild to moderate space as well. So more to come. Thank you for your attention and happy to take questions.
Thank you so much, Dr. Kraft. I think we have a question from Dr. Berger in the chat, so I'll just read it out loud. Dr. Kraft.
Munira,
Yeah.
I could probably just better ask it. But it may have been, and I think some of it evolved as the talk went on. Thank you very much, Dr. Kraft. Amazing talk. Thinking about this, asthma has become, I think, for some of us, a lot more complex than how it was taught in medical school a long time ago.
Absolutely.
And the idea of, phenotypes and endotypes, that is amazing. And the way that you classified it with the type 2s into these large groups, it makes me wonder if there's some sort of genotype we're not seeing yet. And with the goal of precision medicine sort of getting to that level, obviously, identifying markers like you've talked about and focusing on those is a great way of doing it. But from the outset, do you envision at some point, as you were sort of saying there, some sort of genotyping or a more crude method than really getting into very detailed genotyping like scopolamine typing?
Right. No, this is an excellent question, because I think you've really hit the nail on the head. I will say that the biomarkers we have, which are exhaled nitric oxide, blood eosinophils, IgE, they're pretty rough. And so they can sort of help us group into T2, non-T2, asthma, but they're not all that nuanced. And so the PRECISE trial is looking at those biomarkers that I mentioned, and we'll develop others. So that's good. I actually, really hope we have a day and we may sooner than later, where we can really do more advanced immunophenotyping to really understand what the immunology is in a given patient. But then there's also another side of the coin. There's a whole microbiome side, which I didn't talk about today because that's a whole other talk in and of itself. So I'm actually working with a company out of Denver who does some next gen sequencing, and they're doing it with induced sputum right now, which of course is a barrier. Eventually they want to get to nasal swabs, which would be fabulous, where they can actually do a lot of more really deep immune phenotyping, as well as look at the microbiome. And through some really nice advances in that space, they can decide if these microorganisms are present, or if they're replicating, or if they're literally contributing to the phenotype. So I think something like that, having that kind of a tool would be fantastic, because one of the challenges I have with these patients is that they fail these biologics. Like, we see a lot of partial responses to these biologics. They sound like the best thing since sliced bread. I might have made them sound that way, but reality is they often don't do it all. And so patients are still symptomatic. That's why we have the PRECISE trial. And so is it because we're missing something around what you say, around looking at specific genetics, as well as the immune system in more depth, and then this whole microbiome. So I think it's a really active space. There's also the whole piece on artificial intelligence and machine learning that is also sort of being looked at as well, because there's really layers of data if we think about these phenotypes, right? We have the clinical characteristics, we have the immune piece. If we add the microbiome in, then we add the imaging, we add any other pathology. You can see how it can get complex, and eventually it'd be fantastic to have sort of an AI algorithm, right? Where you can really do that quickly in the clinic and then know exactly what your patient has, and then be able to really put together the right therapy. So I think more to come, but your question was perfect, because it really opens, it really suggests there's a whole new world available to us now that we didn't have before.
Thank you so much, Dr. Kraft. Thank you for that question, Dr. Berger. Anyone else with questions for Dr. Kraft, comments?
I just, if it's okay that I ask just really quickly, I think that would be amazing if we could get to that space in AI.
I know.
As a primary care doc, I think my question is, until we get there, how are we going to kind of step into this on the primary care side?
Exactly.
For specialty care.
Perfect. So at this point, I think, because what I would love to work, and actually have spent a lot of time working with primary care physicians, because I think that there is an unmet need there in the asthma space in terms of knowing how to phenotype, and then knowing when to get some help. And so certainly in any patient, getting blood eosinophils is reasonable, because you want to see if there's sort of a type 2 signal there, regardless of severity. I think looking at comorbid conditions is key, because there's this whole debate about poorly controlled asthma versus severe. So poorly controlled could be that way simply because the sinus disease isn't taken care of with nasal rinses and nasal steroids. The reflux isn't treated effectively, because that can lead to bronchoconstriction. Sleep apnea hasn't been addressed. There could be vocal cord dysfunction that can mimic asthma and result in very high medication burden when it's not even asthma at all. And then the other question is making the diagnosis, making sure there's lung function obtained, really spirometry with a bronchodilator response to see if you have evidence of airflow limitation or reversibility is really important. So the lung function should improve with a bronchodilator, assuming they held their inhalers, by 12%, 200 mils. Now you don't even need to remember that. You'll just know when you get the interpretation that it'll tell you if there's a bronchodilator response. So there's confirming the diagnosis. There's also looking at comorbid conditions. Then there's making sure that they're on an inhaled steroid and even a long-acting beta agonist if they need additional treatment. And are they adherent? That's a huge issue. I had mentioned with the patient I presented today that I think she was, but that's a real challenge in chronic disease management. And a typical thing that'll happen in asthma is the patient will be really great for about 4 weeks or so when they come to you, 6, and they start to feel good. And then they say, well, I don't really need this inhaler. I'm feeling good. I'm going to stop. And then about 2 or 3 weeks later, they feel bad and they don't know it's because of something they did so long ago. So it's important to sort of explain that to them. and also help them with the device use. So there's a lot of sort of pieces to asthma management. I would say though, if you're at the point where you feel confident with the diagnosis, you've treated the comorbid conditions, you think they're adherent, yet they're still having asthma attacks, poor symptom control, lung function is abnormal, that's a time to think about referring to allergy or pulmonary for additional treatments. That's what I would think. So hopefully that's helpful.
Yeah, thank you. I mean, I think that's kind of where we were at. And then
Good.
I think omalizumab was one of the first new
Yeah,
therapies back, I will say now.
back in the day. Yeah.
Where I think in the primary care space, one of the things I remember omalizumab actually came out when I was a resident, and one of the things that we were kind of learning about is should we really be checking IgEs in the primary care
Yes,
space?
I would do I total IgE, especially if there's allergy. I would do allergen specific skin testing as well. You can do skin testing or blood. In the primary care space, just like in my practice, I just send them for the blood tests.
Yeah.
And you want allergen specific IgE. And if you think that allergy is really driving a patient's asthma, then there's certainly a lot of things you can do around, treating the rhinitis, and then thinking about, well, if they're mild, maybe allergy shots might be a way to go versus omalizumab. And that's where your friendly allergist or pulmonologist can help you with that.
Fair enough. Thank you so much.
Sure.
Thank you
All
so
right. Yeah, it's about 2 minutes before the hour. I think this is time to wrap up, but thank you so much, Dr. Kraft. Really appreciate your time and that fascinating presentation.
Sure. It's great to see you all. Thank you for being here, and look forward to more interaction. That's for sure.
Thank you so much,
All right.
Dr. Kraft. Thank
Take
you
care.
everyone for joining. Have a nice day.
Bye-bye.